Good day. My name is Carlene Fider, and I am an assistant clinical professor in the School of Interdisciplinary Studies at Loma University. I also support research and program development in the School of Nursing through a grant that is provided by HRSA. Today, we're going to be talking about something that is often invisible in both research and practice, reproductive health for people with sickle cell disease and sickle cell trait. Reproductive health is not a side issue in sickle cell disease and trait care. It shapes decisions about family planning, relationships, identity, and long-term health. However, for many individuals with sickle cell disease and trait, reproductive health education and support are delayed, inconsistent, and often absent altogether. Despite advances in sickle cell treatment, reproductive health remains a critical gap. These gaps don't occur in isolation. They're shaped by individual knowledge, healthcare systems, communities, and policies. When reproductive health needs go unmet, so the consequences ripple outward, increasing health risks, allowing for missed opportunities for making informed family planning decisions, increasing emotional distress, and reducing the quality of life. Improving reproductive health access is therefore not optional. It is essential for equitable care. So to better understand the barriers, we conducted 27 semi-structured interviews with people living with sickle cell disease or traits, caregivers, and healthcare providers. Using the socio-ecological model, we examined how barriers operate across multiple levels, allowing us to capture both personal experiences and systemic failures. At the individual level, delayed diagnosis and limited education were common. Many participants did not learn their sickle cell disease or trait status until adolescence or later, often by accident. For others, cultural and immigration experiences played a major role. One participant described years of unmanaged pain living overseas, repeatedly being misdiagnosed, and only learning the truth about their condition after coming to the United States. Without early, accurate information, individuals are left to navigate reproductive decisions without the tools they actually need. At the community level, stigma and misinformation were pervasive. Participants shared experiences of isolation, friends afraid to touch them, educators minimizing their pain, schools lacking even basic understanding of sickle cell. When schools and communities fail to normalize sickle cell disease and traits, individuals internalize silence, shame, and confusion, especially around reproduction and genetics. Within the healthcare systems, inconsistent screening, limited provider knowledge, and lack of genetic counseling emerge as major barriers. Several participants described being told they had sickle cell traits, but receiving no follow-up, no explanation, and no guidance about reproductive implications. Providers themselves acknowledge that these gaps exist, emphasizing that early identification and counseling could fundamentally change outcomes. And at the policy level, insurance gaps and financial strain result in restricted access. Participants noted that sickle cell is often inconsistently recognized across systems. It may be listed as a disability in some contexts, but excluded in others. And these contradictions can create even more barriers to care, to employment, and to financial support, which directly impacts reproductive decision making. Taken together, these things show that reproductive health inequities in sickle cell disease and traits are not accidental. They're systemic. Improving outcomes require early education, cultural responsive counseling tools, community partnerships, and policy reform. When we address reproductive health proactively, we empower individuals with sickle cell disease and trait to make informed choices, strengthen families, and improve long-term trajectories. This is not just about managing a condition, it's about dignity, autonomy, and equity across the lifespan. We would like to thank HRSA for funding to be able to conduct this research, our community partners and the participants, as well as the research team. For information specific to our references, feel free to scan the QR code to the bottom right. And if you'd like to get in touch with me, feel free to do so directly at cfider@llu.edu. Thank you so much.